Hey everybody, Dr. Reviso here. In this video, we're going to talk about atrial arrhythmias. There's really three big categories here. We have atrial fibrillation, atrial flutter, and then sick sinus syndrome. So let's just jump right in here. Now, the first thing I want to remind you too, when we're talking about all these different pathologies in this video, we're talking about diseases that are going to be typically originating up here in the atria. So in atrial fibrillation, you have these automatic foci, so these areas in the atria that are going to send off electrical signals that are not the same signals as the SA node, right? The SA node is normally going to be your pacemaker, right? It's going to originate in the right atrium. It's going to send signals to the AV node, right? And that's going to go to the bundle of his, right? And so on. So we've already kind of went through that. But here you have some other site that's generating this electrical impulse. And those electrical impulses are going to get spread throughout the atria. Normally, the SA node is going to be giving you about 60 to 100 beats per minute, right? 60 to 100 of these electrical impulses are going to be sent out. They're going to go to the AV node where there's a refractory period. We're going to delay the conduction so that the ventricles can contract in systole and the atria can contract in diastole. So that's what normally happens here with the SA node. But remember, if you have some site of aberrant electrical activity, this might be conducting impulses at 300, 400, 500, 600 impulses per minute, if you can imagine that. So you're sending out 600 impulses per minute. That's going to completely override what's happening here at the SA node, right? And so these impulses were going to cause the atria to contract quickly. So the atria is going to be contracting very quickly. And over time, what happens is if this is persistent, if this keeps going on, you're going to eventually get structural remodeling of the atria. Even if it's not at these high of heart rates, you can still get structural remodeling because the heart isn't contracting the way that it's supposed to. It's not following this organized pattern of the SA node originating the impulses and then conducting down, its electric circuit. So over time, if a patient has AFib, right, they get this remodeling of the heart from all of these signals kind of being sent from these automatic foci here, and that eventually is going to increase the risk of getting even more automatic foci, right? When all of this remodeling occurs around the heart, you might get another site here, you might get another site here, and all of a sudden you have all of these different sites firing electrical signals in an uncoordinated fashion. And so you get these very rapid, like we said, very high speed, uncoordinated atrial contractions. So the atria is contracting, and it's contracting irregularly because you have these foci originating from different sites, right, sending signals at different speeds. That's the general principle of what's happening in the atria. The atria are basically just being blasted when you're in AFib, with signals coming in different directions. It could be one automatic foci, it could be many automatic foci, okay? And eventually what will happen is at these very high rates, we'll continue to get remodeling. Now, how does that translate to what we actually see happening? So let's erase this for a second, okay? So again, let's just go through this one more time, right? I have some ectopic foci here. Let's say I have mitral stenosis maybe, okay? And I get some left atrial dilation, and then that dilation leads to some automatic foci or aberrant signaling back here in one part of my left atrium, usually in the vicinity of the pulmonary veins, right? This is where we're typically going to do our catheter ablation. That's what we talked about in an earlier video in the cardiology series. So again, this is going to send some signal out, right? So it's going to send signals at really high rates, 300 or 400 beats per minute here in the atria. Now, for this signal to get down to the ventricles, remember, it's got to get to the AV node. Okay, so here's my AV node. We'll just put AV here. And then it's got to go to the bundle of his and eventually go down to my left and right bundles, and then to my Purkinje fibers, right? Okay, so that's what has to happen. Now remember that the AV node, this AV node actually has a refractory period. The whole point of the refractory period is so that it can slow down the signal coming from the SA node. Okay, remember the SA node is going to send a signal, and then there's a refractory period before that signal can get through the AV node to the ventricles, and that's how we kind of separate the time between diastole and systole. So if you have a patient that has AFib and this signal's coming in hot, right, it goes right into this AV node, but it's intermittently going to be refractory. It cannot consistently, as it's getting bombarded with these signals, not all of them are going to get through, okay, because it's going to have time periods where it's refractory. That's kind of what we know the AV node to do. It has a refractory period. So you might get some of these signals through, but you might not get all 300 beats per minute through. Instead, you might get, 120 or 140 beats through, okay? Typically, this is going to be between 100 and 175 beats that are actually going to get through the AV node and get into the ventricles. So if you look at AFib on an EKG, my point is, when you're looking at AFib on an EKG, do you see 500 beats per minute? No, you never see that. You see between 100 and 175. That's typically called rapid ventricular response. It means that these signals that are coming from this automatic foci are getting through the AV node and into the ventricles. And when you look at that on an EKG, again, because not all the signals are making it through the AV node because it's intermittently refractory, it's not conducting all of the signals, the heart rate usually is between 100 and 175. So here is a great example of one of these EKGs. Now you can see the thing that we're looking for is this irregular rhythm. Okay, it's irregular because you have different foci conducting different signals, kind of in all different directions, and only some of the signals are actually getting through. And so it's a completely irregular rhythm. And a great way to do this is just to look at the distance between these QRS complexes. Okay, so you can see here we have about 1.5 boxes. Here there's this huge gap of 3.5 boxes. Here's about 3 boxes, right? So you can see that there's completely irregular spacing. There's completely irregular RR intervals between each of these QRS complexes. Now, the other thing that you can kind of see here too is that you kind of have this like erratic baseline here. So it's really hard to actually look at this and say, okay, there's my P wave. You don't really have very clear demarcation of the P wave. And the reason for that is, remember, the signal's not originating at the SA node. The signal from the SA node is really what's responsible for atrial depolarization. Instead, you have these signals kind of going in every direction sporadically. And so the EKG is picking that up. It's giving you this erratic baseline with no clear P wave. So that's the other thing to just be on the lookout for. You have this absence of P waves. Now in a normal EKG, right, what we would expect to find is we have a normal RR interval. Here we have about 4 boxes, 4 boxes, 4 boxes, right? And then we can also see that we have a very clear P wave that precedes our QRS complex. Okay, we have a T wave after for repolarization, and again, P wave, QRS complex, T wave. Here we really don't have that. We have an erratic baseline, no clear P waves, and we have irregular RR intervals here. So let's look at this one. The one on the left now is going to be the normal heart. So keep that in mind. So this is the normal heart. You see the SA node sends a signal to the AV node. And so the atria will contract initially, and then the ventricles will contract after the signal gets through the AV node. But if we look at this heart, we can see all of this kind of erratic signal in the atria, and then occasionally some of that signal is getting through. And it's completely random as to when that signal is going to get through because so many of them are stimulating the AV node at once. Okay, and so that's where you get this irregular intervals. These erratic QRS complexes are a reflection of the signal that's getting down to the ventricles. In terms of the presentation, you'll see that a lot of these are actually pretty similar. AFib tends to be a tachyarrhythmia. It doesn't have to be necessarily, but it tends to be a tachycardia. Patients will say they have palpitations, shortness of breath, dizziness, they might have syncope. The other big thing you need to remember about AFib is what causes AFib. So the big one here, I would say, is mitral stenosis. Almost always the question is going to be teed up in some way about mitral stenosis. Now remember, what's the most common cause of mitral stenosis? The most common cause in the world of mitral stenosis is going to be rheumatic fever. Right? So rheumatic fever is the big cause of mitral stenosis that you really want to keep in mind. So if you're going to get a board question on AFib and it's going to be about mitral stenosis, a lot of the time it's going to be a patient with rheumatic fever. Remember, what are the signs of mitral stenosis? How do they ask you about mitral stenosis in a question? It's going to be a patient that has an opening snap, usually a mid-diastolic murmur. Remember, there's not a lot of diastolic murmurs. There's mitral stenosis and aortic regurgitation. And anytime you have a diastolic murmur, that is not a good thing usually. That's usually going to be abnormal. Diastolic murmurs are not flow murmurs. They're almost always pathologic. Now, what are the other causes here of AFib? So cardiovascular disease in general, patients that have coronary artery disease, heart failure, hypertension, and it's the same concept, right? If you have coronary artery disease, if you have heart failure, there's remodeling of the heart. When there's structural remodeling of the heart, especially some fibrosis or dilation of certain chambers of the heart, that predisposes the left atrium in particular to atrial fibrillation. The other thing is hyperthyroidism. This has to do with excess sympathetic activity. It's causing this increased level of electrical conductivity in the heart. Same concept here, increased sympathetic tone. Anything that does that could be a pheochromocytoma, cocaine, amphetamines, alcohol use. And you always want to assess patients for this, right? You always want to figure out what is the root cause. Because, for example, if you have a patient that has hyperthyroidism, you can get a TSH or a free T4 and say, hey, this patient has hyperthyroidism. That might be causing their AFib. And so you can treat that, right? Okay, so just keep these precipitating factors in mind. Usually when you get a question on AFib, it's usually, and I like to think of things in terms of threes. I know there's 4 things on here, which is kind of bothers me a little bit, but these are really the big 4. Like if you can remember these 4, you can even put hyperthyroidism here with increased sympathetic tone if you wanted to make it simple. But if you know these, this is usually how atrial fibrillation is going to get presented to you in a board question, especially if they're not overtly giving away that it's AFib. Now, the biggest thing about AFib, and this is especially true in real life, whenever someone has AFib, the first thing you start to think about is embolic phenomena. And so the concept here is, right, if you have an atria, right, if your atrium is not beating the way that it's supposed to, right, you might have this area of the atrium contracting at 1 minute and this area might be contracting at another. Okay, and so the concept is that's where this irregularity comes in. It's irregular because different areas are contracting when they're not supposed to, because you have all different signals being sent in different directions, right? Especially if you have a whole bunch of different foci. And so what's happening here is because the atria isn't really effectively moving blood, all the blood that's sitting in the atria isn't really moving very far because there's not coordinated contractions. So what happens if your blood sits? If you cut your hand, the blood will clot faster if you put pressure on it. You're preventing the blood from moving, right? So when blood doesn't move, it clots. And if you can't effectively contract and get this blood out of the atrium, right, that blood is usually going to clot. Okay, so that's the concept. So now if you start to develop clots, right, if you start to develop one big clot, you can develop an emboli here. And that, when you do have a good contraction, or when you get this emboli past the mitral valve and you get it into the ventricle, now guess what? The ventricle can contract in a coordinated fashion, potentially, and get that clot to go right up to the brain. Okay, and it doesn't have to go just to the brain. It could end up going to the kidneys, right? You can get a renal infarct. It could go to the limbs, right? So there's a lot of different places this embolus can go. The big one that you're worried about is the brain, because if that clot goes up to the brain, right, it can block your internal carotid artery, it can block your middle cerebral artery, things that we talked about in the neurosection. So that potentially can cause an embolic stroke. Okay, so the embolic stroke is the biggest thing you really worry about in a patient that has AFib. And for that reason, a lot of these patients are anticoagulated. And we'll talk more about the rules for that. You don't really have to know much about that for step one, but this is the big thing you want to remember, is that you can end up with embolic phenomena from AFib. And again, it doesn't have to go to the brain. This is the classic way they ask the question, but they can ask it about the kidneys. You can have renal infarctions, you can have acute limb infarctions, right? You can even have splenic infarctions, you can have intestinal infarctions, right? Those are all very classic. So just keep that in mind. When you have a question on AFib, you think about an irregular rhythm, look for the classic causes, and always remember those questions are almost always associated with embolic phenomena. An easy way they tee that up is they give you the EKG, and in some way they're testing you on an embolus at a certain location, whether it's the limbs, the kidneys, the spleen, the intestines, the brain. Those are all things to keep in mind. The classic place that this tends to form, these emboli tend to form, is the left atrial appendage. So just remember that. That's particularly high yield to remember. Some other major complications, not quite as high yield. Pulmonary edema is a big one. This just goes back to your hemodynamics, which I'll talk about in a second. The concept is if you have very ineffective contraction of this atrium, remember that blood can kind of just sit here and it can back up, and this will back up into the lungs, right? And so that's where you get the pulmonary edema. Ventricular tachycardia you can get too. We already talked about rapid ventricular response. That signal is getting moved down into the ventricles and you're contracting at a very high rate. That can lead to a ventricular arrhythmia potentially. So when we're talking about AFib, usually you'll see either rate control or rhythm control. So these are kind of two ways to control the atrial fibrillation. Now the first concept is, look, if I have again, going back to that same concept, so you have all of these signals coming in from the left atrium, and they're all going to eventually hit the AV node, right? And they have to get through this AV node for them to go to the ventricles. And the AV node has that refractory period. So it's going to be intermittently refractory. So it's only going to conduct some of these signals, but not all of these signals, right? And so that's the concept. So what I can do is I can say, look, if I can find a way to kind of inhibit this calcium current. Remember, the AV node is going to be one of our pacemaker cells, right? So you're going to have, a pacemaker potential curve that looks something like that. If I could find a way to kind of delay this, right, that would make it so that less signals might get through my AV node. How can I delay this? Well, remember that this depolarization phase that we talked about before is due to the L-type calcium current, right, on the pacemaker potential. So remember, beta blockers, what do these do? Those are going to decrease your levels of CAM. Remember, beta 1 is G protein coupled receptor, right? If I block that, I can decrease my levels of CAM, and that will eventually cause decreases in calcium. and that will push this L-type calcium channel current over to the right. It will delay it, so less signals will get through. The same concept is true for calcium channel blockers, right? We're blocking calcium channels. Both of these will actually help me out in that I'm gonna get less signals conducted or slower periods of conduction through that AV node. So I'm gonna have more of a refractory state potentially in my AV node when I use these medications. So that's the general concept for beta blockers and calcium channel blockers. Now, what about digoxin? Well, I told you earlier, digoxin is actually very useful for two things. The first thing about digoxin is that it has parasympathetic stimulation to the heart. So for digoxin, number one is going to be your parasympathetic stimulation to the heart. Specifically, this parasympathetic stimulation, right, it's going to actually slow the conduction to the AV node, right? Parasympathetic stimulation is going to be associated with lower heart rates. It's going to slow my conduction to the AV node. So that's the first thing digoxin is going to do. And you can see why that's helpful. Again, we want to delay as many signals as we can from getting through the AV node into the ventricles. It's going to keep my heart rate down and allow me to have more effective contractions in the ventricles. So again, that's why these are all rate control. They're controlling the rate that these signals can get through the AV node. So that's number one. Number two, digoxin also causes increases in contractility. Okay, so it actually causes increases in contractility. Now this increases in contractility, these are going to be in the cardiomyocytes. Okay, so think about the ventricular cells. Whereas when you're talking about this parasympathetic stimulation, you're mostly talking about SA and AV node. And then contractility, mostly cardiomyocytes by increasing calcium indirectly. That has to do with what we talked about before, where you're going to inhibit your sodium potassium ATPase. You have more sodium build up, right? You have more sodium build up intracellularly. And to get this sodium out, there's a sodium calcium exchanger. And so in exchange for sodium, you're going to get higher levels of calcium in cardiac myocytes. And calcium is associated with contractions. This has to do with all the stuff that we've talked about in the previous videos. Okay, so if you're not familiar with that, go back, check out those videos. But that's what we're talking about. Digoxin, two major effects. Parasympathetic stimulation to the SA and AV node, right? It's going to slow my impulses in AFib that are getting through from the atria. And then number two, it's going to cause an increase in contractility. So for that reason, it's very useful in systolic dysfunction. So if I have AFib because of heart failure, remember that's one of the classic causes, right? I'm going to be able to slow down the AFib with parasympathetic stimulation, and I can actually increase my contractility as well in systolic dysfunction. Would be great, right? Because that's the primary problem in systolic dysfunction in heart failure. I don't have enough contractility. So digoxin is very useful in that sense. So that's rate control. Now, what about rhythm control? So rhythm control is going to have to do with our antiarrhythmics. So you already kind of talked about these a little bit, and I'm going to go through them kind of fast. If you're not familiar with some of the stuff, go back, watch the antiarrhythmic video where I talk about these in a little bit more detail. Now, remember, the class 1C antiarrhythmics have a lot to do with use dependence at high heart rates. So we talked a little bit about this use dependence. So as you get up to these really high atrial heart rates, these class 1C antiarrhythmics work very good. So they work very good at high heart rates, okay? So that's kind of my way of remembering that the class 1C are going to be very useful in these patients in particular. Now the class 3 antiarrhythmics, these, remember, inhibit the potassium current. So if we go back to our curve here, if it looks something like this, right? The phase 3 antiarrhythmics are primarily going to act, kind of delay this phase. And so the idea is I'm prolonging my QT interval, that's number one, but I'm doing that by delaying my repolarization. And in doing that, I'm increasing my absolute refractory period. And if I have a longer refractory period, right, then I'm going to have less of these conductions that are coming through that are causing me to generate action potentials, okay? So longer refractory period is definitely a good thing in these situations. So in one case with class 1C, we have really good use dependence at the high heart rates we see in AFib. And in class 3, we see a little bit of this potassium channel inhibition that's used to increase the absolute refractory period, causing less of these conductions to get through. And then amiodarone, which actually has effects of class 1C, it has effects of class 3, it has effects of class 2, which are beta blockers, and class 4, which are calcium channel blockers. So amiodarone kind of has effects of pretty much everything on this page. And so that would make sense that amiodarone works well. You're going to have AV node conduction inhibition through inhibition of L-type calcium channels, and you're also going to have great delay of this potassium rectifier current, increasing your absolute refractory period. Also, call your attention to sotalol on here. Remember, sotalol is a beta blocker. So again, you're getting some of the beta blocker effects, and you're getting some of the class 3 effects of inhibiting this potassium channel current, that's going to cause delayed repolarization. So you get kind of a 2-for-1 deal with some of these. Again, on step 1, they don't ask a lot about, what is the best medication? What's the first line medication? That's more of a step 2 thing. But on step 1, you do have to know mechanism. So you have to know that sotalol is going to have class 2 antiarrhythmic effects, right? It's going to delay conduction through the AV node, but it's also going to have class 3 antiarrhythmic effects where it's going to increase the absolute refractory period. So that's where you want to be familiar with this. And again, we talk about a lot of this in the antiarrhythmic lecture. Now, the thing that gets really confusing about catheter ablation is, sometimes there's questions asking about where would you do the ablation. This is like a very common thing because it tests anatomy. Now, for AFib, you almost always would be right to say pulmonary vein ostia, which are typically in the left atrium. Okay, so if a patient is having symptoms and they haven't had the AFib for very long, it's paroxysmal, that's usually what you want to do. But on the other hand, let's say, weeks or months potentially, right? That would be a persistent AFib. And those patients that are at really high heart rates, that have had AFib for a long time, you can actually ablate the AV node. The idea here is if I have AFib for a long time, especially if I have rapid ventricular response, I don't want my ventricles to burn out. I don't want my ventricles to go into a ventricular tachyarrhythmia that could be lethal, right? And so I want to stop the signal from getting to the ventricles, right? I want to stop all of these impulses from getting through. And so in those situations, for persistent AFib with a rapid ventricular response, it's been ongoing for a long time, and it's not going to help a ton if you just hit these pulmonary veins, because if a patient has persistent AFib, usually there's probably some fibrosis. They probably have multiple sites in that atria that are generating that signal. It's probably more chronic. So in those situations, because you're at high heart rates, you got a lot of signals coming to your ventricles, just shut down the signal that's coming to the ventricles. So in those situations, usually they'll ablate the AV node, which is right atrium. So you can see where this gets kind of confusing in board questions. So just kind of keep that in mind. I'm not going to talk too much about anticoagulation. This is more of a step 2 thing, but just know that patients that have AFib typically will be anticoagulated. There's a scoring system for this. Not going to go into all those details because they're just not as high yield for step 1. Hemodynamics and heart failure, we already kind of talked about. Remember, the idea is if you have left atrial dilation and you're not moving blood through this left atrium, that blood is going to back up. That blood is going to go back to the lungs, right? So it's going to back up into the lungs and you get pulmonary edema. Now, if the pressures get high in the left atrium because you have mitral stenosis, or even just because you have AFib and you're not effectively contracting the atria, you're going to increase your left atrial pressure, which again is synonymous in many ways by the pulmonary capillary wedge pressure. So remember that. Now, if you're not moving blood forward, right, your preload is going to drop. Therefore, your cardiac output is probably going to drop. And again, we already talked about the left atrial dilatation that you can see with AFib. Also, remember the classic finding that we talked about on jugular venous pressure tracings is going to be the loss of the A wave. So remember, this is kind of a rough outline here, but your A wave is up here. So you have your A wave, which is going to be your atrial contraction. And then you have your C wave, which is your tricuspid valve closing. And you have your X descent, which is just, the relaxation, right? The X and relax, the X and the X descent. And then you have your Villing phase, which is going to be V phase. And then you have your Y descent. Okay, so remember the atrial contraction, this is like your atrial kick. Now, you're not really going to have an effective atrial kick if the atria is constantly being stimulated and there's no coordinated contraction. You're not going to get a good atrial kick. So normally you'll get something that looks more like this. It's kind of going to be, you have your C wave, you have your X descent, you have your V wave, Y descent, but you're not really going to have a clear A wave, right? So that's going to be completely gone because you have these random impulses where you're getting random contractions in the atria, but you don't have a coordinated contraction that's big enough to generate this pressure. Okay, so that's very classic for AFib, this loss of A waves on JVP tracings. And this is just to give you a rough idea. We're not going to go through everything on the EKGs, but the big things to look for, you're looking for absence of P waves, and that's usually in the setting of some very kind of erratic baseline, which you can kind of see it here. You can see these kind of bumps here in the baseline. That might be from all of those different signals that are generated at different points in the atria. Okay, you can definitely see some of it down here as well in AVF. Irregular rhythm, right? Look at your RR intervals, right? You have irregular RR intervals, and the QRS complexes will tend to be more on the narrow side in general in AFib. But we'll go through more on EKGs as we go through this lecture series, but we'll definitely go through a lot more than that when we talk about step 2 stuff.